Welcome to The Explainer. Today we are jumping right into a true gastrointestinal emergency, caustic ingestions. We're going to break down everything you need to know, from those first critical moments in the ER, all the way to the long-term surveillance that can save a life years down the line.
All right, let's put ourselves right in the middle of a classic high-stakes scenario. You're in the emergency department, and a patient comes in after swallowing something like drain cleaner. They're in obvious distress, the clock is ticking. What do? This is one of those situations where having a system, a clear plan of action, makes all the difference in the world.
So here's how we're going to walk through this, just like you would in a real clinical setting. We'll start with the immediate triage, then we'll get into understanding the specific kind of injury we're dealing with. After that, we'll talk about assessing the damage, how to grade it, and finally, how to build a plan for both the short-term and the long-term.
First up, the emergency itself. Before you even have a chance to figure out exactly what they swallowed, your only focus should be on one thing: stabilization. These first few minutes are absolutely everything.
It always comes back to the basics: airway, breathing, and circulation. Caustic stuff can cause the larynx and epiglottis to swell up incredibly fast, so your very first move has to be assessing that airway. And you know what? Don't be a hero. Be prepared to intubate early if you have even the slightest concern. Losing the airway is the fastest way this situation goes from bad to worse.
Now, just as important as what to do is what not to do. It might feel right, intuitive, to try and get the stuff out or to neutralize it, but these actions are absolutely forbidden. And here's why. Making someone vomit or doing a lavage means that caustic agent travels back up the esophagus, causing a whole second round of injury. And trying to neutralize it, like an acid with a base, that creates an exothermic reaction. It literally generates heat, giving the patient a thermal burn on top of the chemical one. So just don't do it.
Okay, once your patient is stable, the next thing you got to do is understand the enemy. Is it an alkaline agent or an acidic one? Because they create completely different injury patterns, and that's the key to predicting what kind of damage you're going to find.
This is the core difference right here. Alkaline agents, like your typical drain cleaner, cause something called liquefaction necrosis. The best way to think about it is that the tissue is literally dissolving. It's melting away, which lets the chemical just keep penetrating deeper and deeper. That's why it's famous for causing these horrible esophageal injuries. Acids, on the other hand, do something different. They cause coagulation necrosis. They create this tough, leathery scab, an eschar, that actually forms a barrier and limits how deep the burn can go. And because acids tend to go down fast, they usually do most of their damage when they pool in the stomach.
All right, so the patient is stable, and you have a good idea of the potential injury pattern. Now it's time to actually see the damage for yourself. And this is where endoscopy, or an EGD, comes in as our most important diagnostic tool.
But here's the deal with endoscopy: timing is everything. There is a very specific window where it's safe to do an EGD, and that's within the first 24 to 48 hours. If you wait too long, say after about day 5, the injured tissue gets incredibly soft and fragile. Trying to do an endoscopy then carries a huge risk of perforating the esophagus, which turns a contained chemical burn into a full-blown surgical disaster.
But even within that initial safe window, an EGD isn't for everybody. If your patient is still in respiratory distress, if they have severe chest pain, or if you have any reason at all to suspect a perforation has already happened, you have to hold off. The procedure is just too dangerous in those situations.
So let's say it's safe to proceed. When you do that EGD, you're not just looking around. You are systematically grading the injury. And the universal standard for this is called the Zargar classification. It basically gives us a roadmap for prognosis and what to do next.
So here's the Zargar classification. It ranges from grade 0, which is a totally normal exam, all the way up to grade 3B, which is extensive necrosis, basically dead tissue. Now, the real pivot point here is grade 2B. The moment you see ulcers that go all the way around the esophagus, the risk of long-term complications like strictures just skyrockets to over 75%. And for those grade 3B injuries, the mortality can be as high as 65%, and pretty much every single survivor will end up with severe strictures.
So how do we take that Zargar grade and turn it into a real management plan? Well, this last section is all about that, covering the immediate treatment and the long-term problems that you're going to have to watch out for, potentially for life.
The core of medical therapy here is really just supportive care. We're not reversing the damage that's been done. We're just trying to create the best possible environment for the body to heal. This usually means things like sucralfate to coat and protect the injured lining, and PPIs to cut down on any additional acid injury. Antibiotics? We only use those if we really suspect or have proof that there's a perforation.
And again, just as important is knowing what treatments have been shown not to work. You know, early on, people thought maybe steroids would help prevent scarring. But big studies have shown that giving steroids prophylactically just doesn't prevent strictures. Same goes for putting in esophageal stents ahead of time. It's not recommended as a routine thing.
Now, when we look down the road, the most common and frankly debilitating complication is an esophageal stricture. As that severe burn heals, it forms this dense, tough scar tissue that narrows the esophagus. This leads to difficulty swallowing or dysphagia. A lot of these patients end up needing a lifetime of repeated endoscopic dilations just so they can eat.
But there is one complication that requires the most vigilance of all, and that's cancer. The chronic inflammation and cellular damage from a severe caustic burn dramatically, and I mean dramatically, increases the lifetime risk of developing esophageal squamous cell carcinoma. We are talking hundreds, sometimes even thousands of times higher than in the general population.
And that really brings us to the biggest takeaway from all of this. The workup you do in the emergency department, stabilizing the patient, accurately grading the injury with that endoscopy, it does more than just guide acute care. It establishes that patient's risk profile for the rest of their life. It dictates whether they'll need lifelong cancer surveillance.
So I want you to leave with this question in mind. Think about how your calm, systematic, evidence-based approach creates a chain of events. It stabilizes the patient, it minimizes any more harm, it guides the immediate therapy, and it sets the stage for surveillance that could, one day, catch a cancer early. Your actions today are directly connected to that patient's health decades into the future. It's powerful stuff.